Ladies and gentlemen, we have today with us Professor Pascal Vouhe, leading surgeon in the field of congenital heart disease, who has agreed to discuss with us the management of some typical cases in the congenital heart disease. Pascal, would you like to introduce yourself shortly to our viewers?
Yes, my name is Pascal Vouhe. I am French, as you can easily hear, and I am the head of the Department of Pediatric Cardiac Surgery in Paris, in Necker Hospital, which is a sick children hospital in Paris. It's a small department, but the activity is not small because we operate nearly 800 patients every year, only pediatrics. And among these patients, at least 1/3 is neonates. So we have a very big neonatal activity.
Neonatal surgery is now becoming really the principal work of the congenital heart surgeon. Now, what we would like to know from you is the classical management when you get a notification that in one of the suburban hospitals or somewhere around Paris there is a newborn baby with a transposition of the great arteries.
Yes, as it is not the most frequent situation, but we will go back to the most frequent situation later on. When somebody, usually a pediatrician, is calling saying we have a neonate with a transposition, the diagnosis has been made before, and we ask to send the patient as soon as possible to the hospital. Not in the surgical department, but in the cardiology department, just to be sure the diagnosis is correct, eventually to make other investigations if we feel it is necessary, and to prepare the neonate for surgery, because in nearly all cases, these neonates do not need surgery immediately. We can wait a few days, in most cases with prostaglandin infusion, and to prepare the operation in the best conditions possible.
You mentioned that a substantial proportion of patients will be diagnosed before birth. So it does change your management in a way.
Absolutely. In Paris, and more generally speaking in France, nowadays 80% of the neonates with transposition are diagnosed before birth. And we see the mother before, the cardiologist and the surgeons see the mother before birth, and we ask to the mother to come to Paris to deliver the baby, just to be able to get the baby immediately after birth if he needs urgent Rashkin procedure or prostaglandin infusion.
And in order to reduce the stress of delivery, are you insisting on cesarean in these cases, or natural birth will still take place?
This is a decision which is made by the obstetrician, but in most cases the baby is delivered through natural delivery.
Mm. And when you're having the, say, intrauterine diagnosis, do you have an idea of the false positive? I remember the terrible times about 10-15 years ago when abortions were performed due to false diagnosis.
This is not the case anymore, because it's quite easy to make the diagnosis of transposition, because in a normal heart both arteries are crossing each other. In transposition they are parallel to each other, and this is something which is, I am not of course a cardiologist, but they say that this is something which is very easy to see and to be sure that there is transposition.
Yeah. You started now with the treatment. You try to have the child hospitalized in a pediatric intensive care unit immediately after birth, or if possible have the child delivered in a hospital which has such a. How long will you keep the child there? What kind of a stabilization would you consider optimal?
It depends, of course, but usually we schedule the operation at the age of 4 to 5 days of age. And
the reason why?
The reason why is, for the first, I must say that the main reason is to organize the surgical schedule.
Logistics.
Yeah, absolutely. But we thought at that time, at one time, that maybe it was a little more easier or less dangerous, less risky to wait a few days before doing cardiopulmonary bypass and surgery. I'm not sure it is true, because this is the usual way. But sometimes we do surgery before, immediately, one day, 2 days, if the baby is unstable or if he's very blue. And in other cases, we wait a little bit more. For example, if there is some suspicion of infection, we may wait until the end of the first week.
What additionally would you look at? That's what the people would like to know.
Yes.
You, beside classical clinical signs of an infection of a, let's say, a temperature or
Right.
hyperpnea.
And this is a difficult point, because as most of these neonates need prostaglandin infusion,
Yeah.
they may very easily get tachycardia, fever, and a high level of white cells. So probably the platelets are very important. When the platelets are low, it is usually a bad sign, and we have to wait. We rely very much on platelets.
Yeah. You mentioned that obligatory prostaglandin infusion. Is it main purpose is just to keep the duct open, or are there additional benefits?
No, this is not obligatory, and even more, we try to stop prostaglandins before surgery. If the child is stable, not too much blue, we stop prostaglandins. Of course, one of the advantage of having prostaglandin is to keep the duct open and to keep the left ventricle prepared for systemic workload.
Exposed to a high pressure.
Yes, certainly.
Previously, the balloon atrial septostomy, or Reshkin, was considered a must in these cases. You mentioned that it is by far now not the standard procedure anymore.
Not the standard, but every time the neonate is too blue, we do it. So that means that at least 75% of neonates still have a Reshkin procedure.
Will have,
yes.
Yeah. And when you say the logistics of it, there are usual problems, operation at nights, operation and Saturday evening, Sunday morning, where some of your local support and logistic support, I mean about the blood bank and some things, might not be present. Do you try to put a baby like this into a regular program on a daily basis, or will you do it regardless of time?
No. The switch operation for a simple transposition is always put in a normal schedule. Where it is never done as an emergency during night or even during a weekend. It is put.
We have now the baby comes there. You have decided, scheduled for the operation, and you are satisfied with the echo alone. Are there situations where you might insist on additional angio if there is some problem of the descending aorta or the aortic arch? Or
You're right. This is the only situation in which we ask for something else, when there is a suspicion of aortic coarctation or aortic arch hypoplasia, which may need something more on the arch. And we don't do an angiogram now. We do a CT scan.
And because you always inject some contrast media, will you have a certain waiting period after this examination, or will you proceed with the surgery on the same day?
We do surgery the following day.
Mm-hmm. Now, we are coming to because this is going to be a teaching conference here. You are taking the patient to the operating room. One of the important things is, of course, to have a specialized anesthesia team in a specialized operating room. Do you, for instance, pay attention to the temperature in the operating room or during preparation for the operation?
We keep the baby as close as normal to the normal temperature, keeping the breathing during the preparation of the baby.
So you'll be covered and with a heating blanket?
Absolutely. not blanket, but I don't know the name in English, but we're eating procedures.
And what kind of a monitorization do you request from your anesthesiologist before going into a transposition? What do you do except radial and central venous line?
That's all.
That's it.
And now we are using NIRS to monitor the cerebral perfusion. Yes.
So there is additional monitoring
Yes.
for it.
Which is near-infrared spectroscopy, which allows a good monitoring of the brain perfusion during bypass.
Yeah. And how often do you have to react with changes of the perfusion, perfusion volume, the flow of the perfusion, or something according to the near-infrared?
We have a very, not special, but our protocol of perfusion in neonates is rely on normothermia. We use normothermic cardiopulmonary bypass, and we use normothermic cardioplegia.
And
so we have
cardioplegia
very high.
Only antegrade or?
Only antegrade. Yeah. The first dose is given into the ascending aorta, and then every 10 minutes we give additional cardioplegia directly in the coronary
arteries.
Yes.
And you are not worried about the manipulation of the coronary ostia. Usually, what type of the cross clamping will you be dealing with when you're doing yourself? Let's say lever side pulmonary stenosis,
yes.
VSD.
Simple transposition. It's between 60 and 80 minutes of
a cross clamping,
which may seem quite long, but we take the necessary time to do things right. And because we rely very much on our technique of myocardial preservation, we don't try to speed up the operation, and we do all the operation under aortic cross clamp. We don't do anything with a beating heart.
And will you be infusing after you put the coronaries back in and reanastomosis? Will you be then infusing again into aorta itself?
Absolutely.
So not
the last dose is given into the aorta while we reconstruct the aortic, the neopulmonary route.
There were some observations previously when in adults, it was not done in infants, that there might be some damage of the coronary arteries by the cannulas. There may be some late intimal hyperplasia.
Yeah.
I have seen it myself in adult patients with a repeated cannulation. Have you ever seen it in?
This has been said also for neonates and for children. And as you know, we were probably the first group to report coronary lesions after switch operation 10 years or 15 years ago.
Yeah.
And this was something which was said by other groups. You have coronary lesions because you are infusing cardioplegia directly into the ostia. But finally, now that nearly everybody is monitoring the coronary arteries after an arterial switch, the incidence of coronary lesions is quite the same, whatever is the technique of myocardial preservation. So I cannot say this is not true. Probably some patients may get coronary lesions because of that, but I don't think this is a main problem.
Now, if you have additional lesions at liver site, the VSD, which will be just closed during primary procedure, but if you have some malformation of the pulmonary valve, of the, let's say, of the anatomic pulmonary valve, would it influence the timing of surgery in any way, or will you do it regardless?
You mean the pulmonary valve, which is going to become the aortic valve?
The aortic valve.
Which is quite not usual, but not rare, is bicuspid pulmonary valve.
Yeah.
We don't care about that. We do a switch exactly as we would do with the normal pulmonary valve. Recently we studied this group of patients.
And what the result?
And the results are that the immediate results are good, but we had some problems late on the aortic valve, and at least 2 patients needed reoperation to replace the aortic valve, and even one had, in addition, an ascending aorta aneurysm, and he needed a Bentall procedure. So probably there is something around this valve.
Was it also in association with the coarctasia? Because there are some reports about the different anatomy of the coronary or the aorta of the ascending aorta if you have additional coarctation, which would be more prone to dilatation and associated with the bicuspid valve.
For this patient, this was not the case, but probably, as you know, in one group of this patient which is very difficult to deal with is transposition VSD coarctation, because in addition, very often the right ventricle is a little bit small, and we may get problem with the tricuspid valve, which is small and so on. And it is, I don't remember the numbers, but it is true that this is in this group of patients that we find a lot of patients with bicuspid pulmonary valve.
In this particular group, when you expect a smaller right ventricle, are you also making a preparation for some kind of a decompression procedure, let's say a bidirectional cable pulmonary anastomosis, or just leaving the ASD open after surgery?
First, this is controversial, but I always leave a small ASD after a switch operation. I don't close the ASD which has been made by thoracic completely, for two reasons. The first reason is that you are not sure that some left ventricular dysfunction is not going to occur. Even in the best conditions, you may have a period of low output due to some left ventricular dysfunction. So in these cases, the ASD is going to work from left to right. But in other cases, you may get some pulmonary hypertensive crisis or some problems which are linked to the size of the right ventricle, and the ASD may be beneficial from right to left. So I always left the
You
ASD.
observe sometimes problem with the desaturation if you experience a period of right ventricular decompensation.
Yes.
And how do you deal with this?
No, we very often use nitric oxide, even sildenafil if necessary.
Any tricks when you open the pericardium first? How do you deal with the thymus? The thymus could be substantial.
Yes, I remove it completely.
And you're not worried? There have been some big discussions about
yes,
it.
not only discussion, because we did, not we, but a group of immunology in another hospital in Paris, in Salpêtrière. They asked to see our patients. So we have found a group of patients with transposition who had an arterial switch 10 or 15 years ago, and they studied these patients. And they have found some small modifications in the immunology. I cannot tell you exactly, but they are not normal.
It's normally concerning T lymphocytes.
Yeah, absolutely.
They would be at a lower level.
But without any evident clinical
because usually some thymus material will be left above the innominate veins, so you are not really removing everything, just removing any tricks about opening the pericardium? Do you open in the middle, or do you leave some pericardium as a reserve?
Not on the medium. I open it on the left, because I'm using the pericardium to reconstruct the pulmonary route. So on the left, a little bit on the left.
And when you start with the cannulation of the aorta, any particular preferences for the cannulation? You go very high up, or
very high, at least at the level of the innominate artery, even a little bit more distal on the arch.
Into the arch.
Yes, and we use a very small cannula, which are made only for us, and they were used at the beginning for dialysis, and they are very small. So I think it's good material.
You know the French size of it?
I don't know, but no. This is made for us, but this is available on the market, so it's possible to buy.
And the venous cannulation will be bicable, a classic?
Bicable with a right-angle metallic cannula.
And then you say you do always a normothermic preparation. How much will you be preparing the aorta and pulmonary artery before you put the cross clamp on? How much dissection will you be doing?
Nearly nothing. Just separating the aorta and the pulmonary artery, and immediately I put the clamp.
I put the clamp high up.
But I dissect the duct immediately after having put the arterial cannula, and I close the duct
of course,
immediately.
You get to my bleeding. And the pulmonary arteries, how far down they will be? You cross-clamp the aorta, you put aorta up, and then what you do next?
So I cross-clamp the aorta, I cut the aorta just at the middle, and I dissect completely the aortic root and the pulmonary root as far as possible down to the heart.
Yeah.
And then I cut the pulmonary artery near to the bifurcation. And then usually at this stage I remove the coronary buttons.
Yes. And if you look at these coronary arteries and surprises happen, you know, if you are dealing with the intramural course of the artery, how will you dealing this, especially if it comes close to the commissure? Will you detach the commissure?
This is two different things. You may, first of all, if you will, it is very usual to have one coronary artery very close to the commissure.
Yeah.
I think this isn't a problem. We completely detach the commissure and detach the coronary button as usual. And then, after having put the pericardial patch on the arterial root, you can reattach the commissure, and there is absolutely no problem with that. So only commissural origin is not, in my opinion, a big problem. But if in addition you have an intramural course, this is of course much more difficult. I think this is difficult because the intramural course is more or less stenotic. So it's, in my opinion, it is absolutely necessary to remove completely the wall which is common between the aorta and the coronary artery.
Basically unroof, what they call unroof the coronary artery.
Exactly.
And what will you be used for covering of this unroofing pericardium? When you have to reconstruct it back?
Yes.
Because, for instance, on the left you will have to go basically to the bifurcation of when you are unroofing it.
Yes, but
the sutures which you are using for reconstruction, we are jumping forwards, but if you have it's a worst case scenario, if you have putting the pericardium on, what kind of a suture will you use?
On the coronary artery?
On the
9-0.
9-0 resorbable suture?
No, because it doesn't exist.
No.
There is no 9-0 resorbable.
Yeah, I know.
For many years I was using 8-0 PDS for everything, but this is not available anymore. So for a switch, I'm using 8-0 for all the sutures, and if I have something to do on the coronary arteries, I would use a 9-0.
And then when the coronary arteries are ready, what is the next step? You have detached the coronary arteries.
Yes.
And then
at this myself, I immediately put the pericardial patch on the root, on the neopulmonary aortic root, because this is very easy to do at that stage. I'm using fresh pericardium. I don't put it in glutaraldehyde or something else. And
any reason for doing this or avoiding? Alain Carpentier was telling us for many years that you should always dip it in a 0.2% glutaraldehyde.
To be frank, I did it for many years, and probably since now 10 years I'm using fresh pericardium. I can tell you that when you have to reoperate, for example, it's, the child gets coronary stenosis, and you have to reoperate, you have to cut the pulmonary artery, you are completely unable to see where is the pericardium. It's thin.
If it is a native,
absolutely
unprepared.
It is thin, pliable, no calcification. So I think it's very, very well like this.
I thought always that the only argument for using glutaraldehyde pre-treatment is if you are taking a bigger piece of pericardium, it's much easier to sew because it's stiffer.
Yes,
and
that's
it
true.
doesn't fold in
That's
itself,
true.
disappear.
But if you take the time to put 4 sutures on the corners, and it's really not a problem.
And after you have reconstructed the neopulmonary artery, previous aorta, then when you do next?
So then I do the French maneuver. So that means that
obligatory is Lecomte maneuver.
In a simple position, yes, because as probably in a very few cases in which the two vessels are side by side.
Yeah.
There are cases in which this is not necessary, but in a simple transposition, the aorta is always in front of the pulmonary artery, so I always do a French maneuver. And I put a clamp on the pulmonary bifurcation, take the time to dissect very carefully the duct, because I have, at the beginning of the operation, I have put a silk on the duct with a tourniquet, but I don't tie it at that stage, just because you know as well as I know that it is easy to take the duct and the left pulmonary artery. So I don't cut everything and not even do a knot before being sure that this is really the duct. So at that stage I put a clamp on the pulmonary bifurcation, see very well the duct, and dissect completely the duct down to the aortic arch, even if there is no coarctation, nothing. Put to suture, to silk on each side, and cut the duct.
Using ligature, not a suture.
No, ligature.
But this just in order to get the proper mobilization of the left pulmonary artery.
Yes, and then you have to dissect the pulmonary arteries on the left side and the right side, very far down to the ileum, down to the second bifurcation of the pulmonary arteries.
So it's well beyond the upper lobe artery.
Yes. I think it's essential to minimize the risk of pulmonary stenosis after such operation. I must say that our incidence of pulmonary stenosis is currently extremely low, nearly zero, which was not the case 15 years ago.
And the coronary arteries reimplantation comes now after you have anastomosed neopulmonary artery, or it is when are you putting it in?
So after the French
maneuver.
I cannot say I always do the same thing, but in a usual case, I usually begin the anastomosis between the ascending aorta and the neo-aortic root, which was the pulmonary root.
Yeah.
I usually do the posterior half of the anastomosis. I do that because I think it makes the things more fixed in the mediastinum, and it is easier to see exactly where to reimplant the coronary arteries.
And the sutures will be 8-0.
8-0 also.
Proline.
Proline, yes. And after having done the posterior half of the anastomosis, I choose exactly the site of reimplantation of the coronary buttons. In most cases, I'm using a trapdoor incision, which is more or less across the suture line of the aorta. But I cannot say this is always like this. For example, in normal coronary arteries, type A coronary arteries, I usually do 2 trapdoor incisions on each coronary button. In type D, which means with the circumflex arising from the right coronary artery, I would do a trapdoor incision for the right coronary artery, called right and circumflex, and I would do a punch hole reimplantation for the left coronary artery, which is only the left anterior descending artery.
And what size of a punch hole do you use?
It's 3.5.
3.5.
Yes.
And then when you have the coronaries in, and then you anastomose aorta.
Yes, I finish the anastomosis of the aorta.
But you will keep the clamp on and finish the pulmonary artery?
No, at this stage I will do what I have to do on the ASD.
Yeah.
Close it, as I said before, not completely. Close the right atrium and unclamp the aorta. And I will do the anastomosis between the pulmonary bifurcation and the neopulmonary root on the beating
Basically
heart.
on the beating heart. Yeah. And in the case of the VSD, at what stage will you go to the VSD?
Immediately. I would put the cannula for cardioplegia in the ascending aorta, clamp the aorta, give cardioplegia, and close the VSD.
Do you have sometimes to detach a segment of the tricuspid valve, or you will be always?
I know that this is the usual way to do that in Zurich.
Yeah.
No, usually not. Sometimes if I have some time to detach, I prefer to detach papillary muscle than the valve itself.
Yeah.
But in most cases of transposition with VSD, the VSD is very easy to close.
Very good.
I don't know why, but it is very easy to close.
Yeah, that's correct. And now, by the time you have got it all closed, right atrium is closed, you have anastomosed pulmonary artery. How long do you reperfuse? What are the criteria when you think that the heart is ready to go off bypass?
First of all, as soon as I declamp the aorta, I look very carefully to the heart, to the color, and if with our protocol of perfusion, normothermia, if the coronary arteries are well reimplanted, the heart begins to beat immediately. In 2 to 3 minutes is beating. So if this is not the case, you have to worry. You have to go back to
the coronary arteries
and to see how are the coronary arteries, and if there is any suspicion of malfunction, you have to reclamp and to do it again. It happens to me to do the reimplantation for 3 or 4 times before getting.
Can you give a rough number of how many times would you have, let's say, out of 100 cases, how many times you will have a problem with the coronaries?
I would say probably 5%.
That's surprising that even a man of your experience will have this.
Yes, I don't mean a big problem, but it's very often you have a small part of the myocardium which is not well perfused. It's necessary to mobilize a little bit a small artery. Sometimes, particularly on the left side, you may have a small branch which is going to the anterior wall of the right ventricle, and this may induce some kinking of the left anterior ascending. You may have to mobilize
the conal branch of the coronary.
It is sometimes necessary to cut it at the price of a small infarct on the right ventricle, but it is necessary to do it to get a good perfusion of the left one. So when I say 5%, maybe I am a little bit too high, but it is not completely unusual.
One thing which there is a lot of discussion also among the congenital surgeons, if to do any special protective measures against bleeding. You're dealing with several major anastomoses. It's way back behind the pulmonary artery when you are going off bypass. Are you using any pharmacological means, any local protective measures?
I think the main improvement we made was to use 8-0, because for some years I was using 7-0 and it was bleeding much more. 8-0 with very small needles has reduced very much the bleeding. Nevertheless, I usually put a very small amount of glue, fibrin glue, yes. But very small, just to get no bleeding, and I remove it before closing the chest.
And speaking of the pharmacological treatment, you are of course no aprotidine.
We had before and we used it, but now it's not available anymore. So we don't use it.
Helped.
Yeah, it was very useful.
There were good papers about it.
It's absolutely crazy to remove such a product, but we do not use it and anything else instead of aprotidine.
Would you always have some platelets ready when going off bypass?
Yes.
And fresh frozen plasma or cryoprecipitates and
fresh frozen plasma and platelets.
And roughly, how long would be your average reperfusion after you've taken a clamp off the aorta, you have put a pulmonary artery together, the heart is beating nicely? How long is your period, and what kind of a parameters do you watch when going off?
In a normal case, after unclamping the aorta, I do the anastomosis between the two pulmonary stumps. It takes 5 minutes. Then I would put the tubes I always open both sides of the chest, put the tubes, put a line in the left atrium. That's to monitor the left atrial pressure. And in a normal case, We stop bypass at that time. But means probably 15 minutes after unclamping.
How many cases do you observe when you are unable to close the chest immediately?
Unable, it is very unusual, but we still leave the chest open in approximately 15% of cases. We have some rules for that. We leave the chest open in very small babies, in babies below 2 kilograms, premature baby. Even if he's doing very well, I would leave the chest open. If I have to revise the coronary artery for one reason or another, and even if the coronary perfusion seems to be optimal, I leave the chest open.
Repeated ischemia because it makes edema.
Yes.
Okay.
And finally, in all difficult coronary patterns, for example, intramural artery, single artery, even if the child is doing very well, I prefer to leave the chest open for 1 day or 2 days. I don't see any harmful effect of leaving the chest open.
Yeah. And when you take the baby to the intensive care unit and the chest is open, you say you have given us the figures of 10-15%. What kind of a parameter will you be observing before you decide to close it? Is it just looking at the heart, changing dressing twice a day, or looking at the pressures?
Usually we do not reopen the chest every day, but we leave the chest open with a small tube just to keep
spreader.
Yes, to keep the two half of the sternum widely open
Apart.
We looked at the left arterial pressure and the arterial pressure, and we rely very much on the echocardiography. If 1 day or 2 days after surgery the left arterial pressure is low, hemodynamics is very good, urine output is good, and more importantly, left ventricular function is normal, we are going to close the chest.
And when you are speaking about the echocardiography, do you have the small transesophageal probes, or always it's transthoracic?
It's transthoracic. We don't have very small probes for neonates.
And it doesn't disturb you. Sometimes there is air around. You said you open both
Yes.
pleuras.
That's true, but usually our cardiologists are able to see at least how is the left ventricular function.
And finally, how long will such a baby be kept in a surgical intensive care before you give it to the cardiologist?
If everything is doing well, the baby will be extubated either the first night or the day after surgery, and he is going to live in the ICU after 2 or 3 days, going back to the cardiology department.
Well, Pascal, thank you very much. I think our viewers will be able to courageously do this operation. Now, we will be having from you, some pictorial demonstration afterwards. We will be putting it into this film. Thank you very much for staying with us.
Thank you.